Imagine for a second that you take a pill, right? And this pill perfectly balances your brain chemistry.
Okay, sounds ideal.
Right. But then your schizophrenia still relapses. And it relapses simply because of, like, the tone of voice your family uses at the dinner table.
Oh, wow. Yeah.
For decades, modern medicine thought that scenario entirely impossible. I mean, usually when we talk about a medical diagnosis, there is this immense expectation of precision.
Yeah, totally. It's like engineering, you know?
Exactly. Like you take your car to the mechanic because it's making this weird noise, and they hook it up to a diagnostic machine.
Right, they find the exact spark plug that's misfiring.
You swap out the broken part, and you're good to go. And we like to think of human health in the exact same way. You have a symptom, the doctor finds the broken biological mechanism, gives you the chemical, and boom, you're cured.
Well, it's a really comforting narrative, isn't it? I mean, we crave that binary, clean cause and effect loop. We want our problems to be highly visible and easily categorized.
But then you step into the reality of how human beings actually function, and suddenly that simple engine mechanic metaphor just completely falls apart.
It really does.
So, welcome to the deep dive. Today, our mission is to cut through the noise and give you, the listener, a shortcut to understanding a massive fundamental shift in how we view mental and physical health.
Yeah, and we have a really fascinating stack of sources today.
We do. It's this collection of research papers, medical history, and clinical critiques. And they all center around one revolutionary concept, which is the biopsychosocial model.
It is a bit of an academic mouthful, for sure.
Yeah, try saying it 3 times fast.
Right. But it's arguably one of the most important frameworks in modern medicine, largely because it forces us to look at the messy reality of what actually makes us sick.
Okay, let's unpack this. Stripped of all the academic jargon, the core concept here is that human health isn't just about broken biology.
No, not at all.
It is an entangled web. So you have biological factors like your genetics and neurochemistry, but you also have psychological factors, your thoughts, your emotions, your coping styles.
Yeah, and then the third pillar, the social factors. So family structure, socioeconomic status, the broader environment.
Right, and the biopsychosocial model says you just cannot fully explain illness in isolation. If the old biomedical model was treating the body like a car engine, this new model treats it more like a garden ecosystem.
I love that analogy.
Right, because the health of a plant isn't just about the seed's genetics. It's constantly reacting to the soil quality, the weather, the weeds, and how all those things interact in real time.
The garden ecosystem is a great starting point. But, you know, to really grasp the magnitude of this shift, we have to look at the soil this theory grew out of.
Okay, lay it on me.
Well, if treating the body like an ecosystem is so obviously true, why was medicine treating us like car engines in the first place?
That is a great question.
To understand that, you have to look at how rigid and dogmatic the medical landscape had become by, like, the late 20th century.
Right. And our sources introduce us to this guy, George L. Engel, who was essentially the whistleblower here.
Yes, Engel.
He was an internist and a psychoanalyst at the University of Rochester. And in 1977, he published this paper in the journal Science called The Need for a New Medical Model.
A direct challenge to the establishment.
Exactly. He was throwing down the gauntlet against this dominant assumption that disease is just, a cellular or biochemical deviation from normal.
What's fascinating here is the sheer existential panic that psychiatry was experiencing when Engel actually published that paper.
Panic. Why panic?
Well, the biomedical model had been incredibly successful in other fields. I mean, germ theory, molecular biology.
Well, sure, those things saved millions of lives.
Exactly. But Engel argued that this success had hardened into a dogma that treated the patient as basically a meat machine to be repaired.
Wow, a meat machine.
Yeah, entirely excluding their mind and their social reality. And meanwhile, psychiatry was fighting for its life as a legitimate medical discipline.
Wait, let me stop you there. Are you saying Engel was actually trying to save psychiatry from tearing itself apart in the 70s by forcing them to look at the whole person?
It was an all-out crisis of legitimacy. I mean, on one extreme, you had the anti-psychiatry movement.
Right, like R.D. Laing and Thomas Szasz.
Exactly. And they were gaining immense cultural traction by arguing that mental illness wasn't even real.
Which is wild.
Right. They said it was just a rational response to an insane society. But then on the other extreme, mainstream psychiatry was terrified of losing its medical credentials.
So they doubled down.
They took a hard, rigid turn toward pure biological reductionism. And this eventually culminated in the 1980 publication of the DSM-3.
Under Robert Spitzer, right?
Yes. They stripped out all the old psychoanalytic theories in favor of observable, checklist-style symptom criteria. The implicit message was basically, mental illness is purely a brain chemistry problem.
Got it. And Engel was standing in the middle of this war, basically trying to build a bridge.
Ex-
He was saying, look, mental illness is real, and it is biological, but it is also undeniably psychological and social.
And he didn't just, pull this out of thin air.
Right. The sources point out he was inspired by a couple of key ideas. There was Adolf Meyer's psychobiology, which basically said you have to look at a person's whole life history.
Not just isolated symptoms.
Yeah. But the really big one was Ludwig von Bertalanffy's general systems theory.
Oh, general systems theory is the philosophical backbone of everything we are discussing today.
How so?
So von Bertalanffy described living organisms as hierarchically nested systems. Think of nesting dolls.
Okay, nesting dolls.
You have a cell. That cell doesn't exist in a vacuum. It is nested within an organ. The organ is nested within a person. The person is nested within a family.
And that family is nested within a broader community and society.
Precisely. And Engel's stroke of genius was applying that directly to medicine, to say that a change at any one level reverberates through all the others. Illness is never purely a cell problem or purely a society problem because the levels are causally entangled.
Awfully entangled.
Yeah.
Okay, so if we accept that these nested systems are constantly colliding, how does that actually work in practice?
Well,
Actually, before we get to that, this brings up one of the biggest misconceptions we need to clear up right away.
oh, definitely.
The biopsychosocial model is not just taking biology and sprinkling a little psychology and sociology on top like garnish.
Right. It isn't additive. It's interactive.
It's about the interaction effect.
It rejects the idea that illness is only about the body, but it equally rejects the idea that illness is only about the environment.
And the sources give us a brilliant, concrete example of this interaction. The Dunin gene by environment study from 2003.
Such a landmark study.
Let's really look at how they did this because the methodology is wild. Researchers tracked 847 New Zealanders from the moment they were born all the way to age 26.
Imagine the logistics of that.
I know. And they were looking at a very specific gene that affects serotonin transport in the brain, known as 5-HTTLPR.
Right.
Now, for anyone who needs a quick biology refresher, you can have a short allele or a long allele of this gene. An allele is basically just a different flavor or variation of a specific gene.
Yeah, that's a good way to put it.
And here's the crazy part. Just having the short allele did not make these people more depressed.
No, not at all.
The gene alone predicted almost nothing about their mental health.
Let's be very clear about that finding because it's revolutionary. The biological vulnerability alone was entirely silent.
Silent. Wow.
But the picture changed completely when the researchers factored in the environment. They tracked specific stressful life events over those 26 years.
Like what kind of events?
Oh, job losses, breakups, bereavements, assaults, and among the people who had experienced multiple severe stressors, the ones carrying that short allele showed substantially higher rates of depression and suicidality.
Compared to the ones with the long allele who went through the exact same stress. So it's like a loaded mousetrap. The genetic short allele is the tightly coiled spring. It is highly vulnerable. It's ready to snap.
Right.
But it does absolutely nothing on its own.
Yeah.
It just sits there. It requires the stressful environment to actually step on the trigger, to snap the trap.
That is a perfect analogy. Neither the genetics alone nor the life stress alone explain the resulting depression. It was the physical collision of the two.
Which is the basis of what we call the diathesis stress model.
Yes, exactly. Diathesis just means a pre-existing biological or psychological vulnerability. And this mechanism is so vital because it finally shatters Cartesian mind-body dualism.
Cartesian dualism, meaning the old philosophy from René Descartes that the mind is made of some ethereal thinking substance and the body is just a mechanical machine.
And that the two are totally separate.
Right.
For centuries, medicine operated under that assumption. But the Dunin study proves that the physical biological gene and the psychological experiential stress are inextricably linked.
The lived environment literally reaches in and turns the biology on.
Exactly.
Okay, so a stressful moment triggering a gene makes sense. But how exactly do purely social factors, like the house you grew up in or the specific job you have right now, become physical disease risk decades later?
It does sound a bit like magic, doesn't it?
Yeah, because it sounds like we're just saying stress is bad, but the data says it's hard biology.
This is where we look at how society physically gets under the skin. And the most powerful evidence for this comes from the ACE study, which began in 1998.
ACE stands for Adverse Childhood Experiences, right?
Right. And this wasn't a small trial. It was a massive collaboration between Kaiser Permanente and the CDC, looking at over 17,000 adult HMO patients.
And what they did was survey these adults about their childhoods. They were specifically looking for exposure to abuse, neglect, or severe household dysfunction.
Like having a parent who was incarcerated.
Or a mother who was treated violently or living with someone who struggled with substance abuse. They gave everyone an ACE score from 0 to 10 based on these categories.
Right. And the results weren't just a mild correlation.
No, they found a massive dose-response relationship. If you had an ACE score of 4 or more, your risk for alcoholism, depression, and suicide attempts was 4 to 12 times higher than someone with a score of 0.
Which is staggering.
It is. You also had a 2 to 4 times higher risk for smoking and generally poor self-rated health.
What we really need to linger on here is the timeline. These health outcomes were measured decades after the childhood events occurred.
Right, when they were adults.
And they were entirely independent of the patient's current adult circumstances. A purely social and relational history from childhood had been literally embedded into their adult biological risk profile.
Wow.
It is the exact cross-domain causal chain that George Engel predicted.
Here's where it gets really interesting, though.
Yeah.
Because it's not just childhood trauma, it happens to us as adults, too.
Oh, absolutely.
The sources highlight Michael Marmot's Whitehall studies, which looked at thousands of British civil servants.
Yeah, the Whitehall studies are classic.
Right. Now, the British civil service is highly stratified. You have a very clear hierarchy of employment grades. And the researchers found this undeniable social gradient in health.
Right.
Workers who were in lower employment grades, clerks and messengers who had less status and less control over their daily work, had substantially higher cardiovascular mortality rates than the bosses and administrators in the higher grades.
And that was true even after the researchers rigorously controlled for things like diet, exercise, and smoking.
Which is nuts.
I mean, think about your own workplace right now. The amount of autonomy you have over your daily schedule or the way your boss speaks to you, it isn't just a corporate HR metric.
No.
Marmot's data suggests it is actively signaling your biology. For a long time, scientists struggled to explain how social status could physically stop a heart.
Right, because how does your job title cause a heart attack?
Exactly. But now we have the biological mechanisms to explain it. We have the field of psychoneuroimmunology.
Okay, let me break that word down for everyone. Psychoneuroimmunology, mind-brain immune system. So you're saying feeling trapped in a low-level job physically changes how your immune system functions.
It goes even deeper than just fighting off a cold. The neuroscientist Bruce McEwen called this concept allostatic load.
Allostatic load.
Think of it as the literal biological wear and tear on your body from chronic stress. When you are constantly in a state of high alert, whether that's from childhood neglect or constantly being micromanaged at a low-status job, your body is continually pumping out stress hormones like cortisol and adrenaline.
And over time,
That constant chemical bath damages your cardiovascular system, it inflames your tissues, and it accelerates cellular aging.
okay, let me play devil's advocate here for a second.
Sure, go for it.
Because this addresses one of the common misconceptions in our sources. Just because poverty or low social status correlates with depression or heart disease in these studies, how do we know one is actually causing the other?
The classic correlation versus causation debate.
Right. Couldn't it be that being sick makes you poor and lowers your job status rather than being poor making you sick?
It's a really fair challenge, and it directly addresses misconception 5 from our outline, which is assuming causation just because things correlate.
Right. Co-occurrence doesn't automatically establish direction.
However, rigorous biopsychosocial research specifically designs its methods to rule that out by testing these causal pathways over time.
By looking longitudinally.
Exactly. The Dunedin study followed people from birth before they ever had a job or an illness.
Right.
The ACE study tracked long-term adult outcomes from specific childhood baselines. They aren't just looking at a snapshot, they are watching the mechanism unfold longitudinally. The social environment acts as a precursor that demonstrably modifies the later biological outcomes.
Okay, so we've mapped out the deep underlying mechanisms, genes, chronic cortisol, childhood adversity, social status.
The whole web.
But what happens when a patient actually walks into a clinic today? How does this model change the reality of treatment?
If we connect this to the bigger picture, it dramatically shifts how we intervene. Let's look back at schizophrenia, which you mentioned at the very beginning of the deep dive.
Oh, right, the dinner table example.
Exactly. For a long time, under a strict biomedical model, schizophrenia was viewed purely as a brain disease. The logic was, you treat the brain with antipsychotic medication, and you're done.
But the sources highlight research into something called expressed emotion, or E.
Yes.
Researchers looked at schizophrenia patients who were discharged from hospitals and sent back home. And they found that if a patient returned to a high EE, meaning a family environment marked by high criticism, hostility, or emotional over-involvement, their relapse rates were 2 to 3 times higher within 9 months compared to those returning to low E homes.
And here's the kicker. That was true even when both groups were rigorously taking their antipsychotic medications.
Which is just, wow. A purely biological model has no explanation for that.
None at all. The medication was doing its job on the neurochemistry, but the social environment was overriding it.
It's like treating the brain with medication while ignoring a highly critical family environment is like giving someone top-of-the-line noise-canceling headphones, but leaving them inside a blaring jet engine.
Huh, that's a great way to visualize it.
The headphones are doing their job, the chemistry is right, but the sheer volume of the environmental stress is going to bleed through and overwhelm the system anyway.
That is a much more accurate way to look at it. The system is overwhelmed.
Yeah,
and
yeah,
we
yeah.
should clarify here, addressing misconceptions 3 and 4 from our sources.
Oh yeah, the wellness trend thing.
Right. This is not just some alternative holistic wellness trend, and it's not restricted to psychiatry. This is mainstream evidence-based medicine applied to chronic physical illness as well.
Right, the sources talk about fibromyalgia and chronic pain. For decades, patients with chronic pain were essentially gaslit by the medical establishment.
It was terrible. Doctors debated if it was a real physical disease or if it was just psychiatric.
Patients were told it's all in your head. Or, conversely, they were subjected to unnecessary surgeries to fix a biological problem that didn't exist.
Exactly. But researchers like Robert Gatchell and Dennis Turk showed that chronic pain is a perfect biopsychosocial issue.
Because the pain a patient experiences isn't just a readout of tissue damage, right?
It depends jointly on tissue pathology, the biology, plus their fear avoidance beliefs.
Which is the psychology of how terrified they are to move.
Yes, exactly. And the social reinforcement they receive, like family attention or disability compensation. If a doctor ignores any of those 3 pillars, the treatment usually fails.
So if this model is so proven by the data, and so comprehensive in treating everything from schizophrenia to chronic pain.
There's a but coming, isn't there?
Oh yeah. Why isn't the medical system a utopia right now? We have to look at the backlash and the system failures, because it is definitely not all perfect integration.
This raises an important question about how scientific theories survive contact with the real bureaucratic world. The most sustained academic critique comes from a psychiatrist named S. Nasir Ghomi. In his 2010 book, it's called The Rise and Fall of the Biopsychosocial Model.
The title alone tells you he isn't exactly a fan.
Yeah, he makes his stance pretty clear. He argues that George Engel's original rigorous systems theory has devolved over the decades.
How so?
Well, in modern practice, Ghomi says it has become a lazy, eclectic slogan. Doctors are taught to just consider everything.
To check the boxes.
Exactly. Check the bio box, check the psycho box, check the social box, without any disciplined, principled method for weighing those factors against each other.
Honestly, doesn't Ghomi have a huge point?
He does.
If a doctor just throws their hands up and says, well, you're sick because of a mix of your biology, your psychology, and society, isn't that just a super convenient way for the doctor to never be wrong?
I mean,
It stops being a testable scientific theory and just becomes a vague catch-all where everything matters.
Ghomi would strongly agree with you. He contrasts it with earlier models that, even if they were flawed, at least offered a specific causal theory that could be proven right or wrong.
Right.
The danger of the biopsychosocial model today is that it licenses an undisciplined mentality. But the sources point out misconception too, which is that the domains are not meant to be equally weighted in every case.
Oh, I see.
Like a highly genetic disorder like Huntington's disease leans heavily biological. A stress-reactive condition might lean heavily social. The model requires clinicians to do the hard work of weighing the factors, not just blindly listing them.
But doing that hard work takes time.
So much time.
And that brings us to the structural hurdles, which explain the gap between theory and practice. The sources note that actually doing a proper biopsychosocial assessment takes real time.
It does.
Think about what we've discussed. Sitting down, getting a family history, understanding someone's coping styles, assessing their financial stress and their childhood adversity. Now think about a standard 15-minute doctor's appointment.
It's just impossible.
The financial architecture of healthcare still heavily favors the quick biomedical model.
Let's walk through how that actually happens in a clinic. Imagine you go to the doctor with chronic stomach pain.
Okay, my stomach hurts.
The doctor suspects it's heavily driven by the fact that you are facing eviction and working two grueling jobs. But the doctor can't bill your insurance for systemic poverty and stress.
Oh, wow. Yeah.
The ICD-10 billing codes require a physical diagnosis to get reimbursed. So the doctor diagnoses an ulcer, prescribes an antacid, and rushes to the next room.
They treat the biology because that's what pays, and they completely skip the conversation about the eviction.
Exactly.
The model is praised in medical school and then practically abandoned in the real world because the infrastructure just doesn't support it.
That is the tragic irony. We have decades of data proving how causally entangled these systems are, but our healthcare infrastructure is still built for the car mechanic, not the ecologist.
So what does this all mean for you and me right now?
Well, it means we are in a massive transition phase. But the biopsychosocial model is shaping the future, especially in public health.
Yeah.
You are seeing a major push today to treat housing instability, poverty, and discrimination not just as social welfare issues, but as legitimate, urgent medical interventions.
Because the logic finally holds. If social conditions produce measurable biological disease, then fixing the social condition is healthcare.
Exactly.
And we saw this play out in real time during the COVID-19 pandemic. The sources point out that things like long COVID and the massive decline in global mental health are being viewed through this exact lens.
Oh, absolutely.
You had a biological virus interacting with the psychological trauma of grief, interacting with the intense social reality of isolation and economic collapse.
Right. You cannot explain the outcomes of the pandemic with just virology or just psychology. You need the whole picture.
The systems are inextricably linked.
They really are.
Which brings us to the end of our deep dive. We've explored how your biology, your mind, and your environment can interact to make you sick. But I want to leave you with one final provocative thought from our sources to mull over on your own.
This is one of my favorite concepts.
It's a concept called salutogenesis. It was coined by a medical sociologist named Aaron Antonovsky.
Right.
If the biopsychosocial model explains how this three-part interaction creates disease, what if we flip the script?
Antonovsky asked a brilliant question.
He did. He asked, how can the exact same interaction, our biology, our mind, our society, be engineered to create a sense of coherence that actively keeps us healthy in the face of adversity?
It is the ultimate positive counterpart. Instead of asking what makes us sick, we use the exact same entangled web to ask what makes us thrive.
Remember, we're just your guides to this material. The goal isn't to tell you what to think, but to give you the tools to explore it yourself. So the next time you feel run down, don't just ask which part of the machine is broken. Ask yourself what kind of soil your garden is growing in. Thanks for joining us on the Deep Dive.